Good afternoon, friends. Kindly keep your cell in silent mode so that it doesn't disturb the speakers. We'll start off with the neurology workshop. In fact, in the neurology workshop, neurology is one subject. MBBS ரொம்ப tougher in the மாதிரி feeling. I always dreaded neurology. So when Shyam came to my clinic and told me we'll have neurology, you வேணாம்பா அப்படின்னு. இல்லை சார் கேளுங்க, நீ அப்பதான் தெரியும் நான் நியூராலஜின்னு போட்ட உடனே திஸ் டைம் 45 people had registered. ஒரு சர்ப்ரைஸ், இவ்வளோ பேருக்கு இவ்வளோ இன்ட்ரெஸ்ட் இருக்கு நியூராலஜி, நமக்கு மாத்திரம் தான் இல்லையா அப்படின்னு நினைச்சேன். Anyway, I have to tell a few words about Shyam. Shyam வந்து நான் when I started practicing Mylapore and all early stages, he finished MBBS and came to my clinic. He was helping me in my clinic for a couple of months or years or something like that. Yeah, during the MBBS itself he came. He was working with me. So என்னோட வாரிசு மாதிரி அவனை வளர்க்கலாம் அப்படின்னு நினைச்சிருந்தேன். பட் அதுக்குள்ள டமால் ஆஸ்திரேலியா ஓடி போயிட்டு he did his post graduation in neurosurgery and became a big time neurosurgeon. When he came back after a few years, I was so happy. In fact, Dr. Mishra used to say, I still remember his words. Mishra வந்து I used to attend, உங்களுக்கு எல்லாருமே டாக்டர் மிஸ்ரா தெரிஞ்சிருக்கோம் இல்லையா? He is KP Mishra, everybody. I used to attend all his workshops. Particularly, he used to talk to public on Doctor Public Society meetings. எல்லா மீட்டிங்கும் I used to go. அவரே பாப்பா என்னடா எவ்வளவு தடவை இந்த மீட்டிங் நீ என்ன ஹியரிங் மீ ஃபார் 100th டைம். இல்லை சார், I want to speak like you, அதுக்காக தான் I want to do it. தென் ஒரு நாள் கூப்பிட்டு சொன்னார், இந்த மாதிரி காமராஜ் அரங்கத்தில் ஒரு மீட்டிங் இருக்கு, என்னால் போக முடியல, ஹவு நாட் டு கோ டு டாக்டர்னு ஒரு டாக்கு, நீ தான் நிறைய கேட்டிருக்கேன், நான் ஸ்லைட்ஸ்லாம் கொடுக்க, நீ போய் பேசு. எவ்வளோ பேர் சார் இருப்பாங்க? 20 பேர் தானே சார். நோ ப்ராப்ளம். போயிட்டேன், மோட்டர் சைக்கிள் எடுத்துன்னு போயிட்டு அங்கே நிறுத்தினா உள்ள போனால் ஒரு 2000 ரூபா உட்காந்தான். சார், இந்த 20 பேர் இருக்கிற சார்ட்டர்ட் அக்கௌண்ட் எங்கே சார்னு? 20 பேர் இல்லை சார், நீங்க டாக்டர் கைலாஷ் வாங்க சார் வாங்க கூட்டு போயிட்டோம். மேடம் போயிட்டா எனக்கு நடுக்கிறது, கை கால்லாம் 2000 பேர் மேல. ஃபர்ஸ்ட் டாக், மை ஏஜ் வாஸ் 27 years. அப்போ 27-28 years. எவ்வளவு பயமா இருக்கும் பாருங்க. நடிக்கிறது திட்டினே இருந்தேன். மிஷா இவனா எவ்வளவு திட்டிருப்பேன்னு. அப்புறம் வந்து எல்லாம் சொல்லிட்டு இந்த மாதிரி இன்ட்ரடியூஸ் பண்ணிவிட்டு பேச விட்டான். மிஷா நார்மலி ஹி ஸ்பீக்ஸ் இன் ஹிந்தி. ஹிந்தியில் தான் அவர் ஜோக்ஸ்லாம் அடிப்பாரு. எனக்கு தமிழ்ல அந்த ஜோக்ஸ் தமிழ்ல சொல்ல முடிஞ்சு. அண்ட் தட் ஆடியன்ஸ் வாஸ் மோர் தமிழ். அதனால ஹிஸ் சேம் ஜோக்ஸ் ஐ வாஸ் ஏபிள் டு இன்டர்பிரட் இன் தமிழ். இட் பிகேம் எ பிக் ஹிட். முடிச்ச உடனே எல்லாம் 2000 பேர் எழுந்து நின்று கையில தட்டணும்னா அப்படி கண்ணீர் வந்துடுச்சு எனக்கு. என்னடா இது இவ்வளோ இது இருக்கான. தென் நேராக அவர் வீட்டுக்கு முடிச்சுட்டு மோட்டர் சைக்கிள் போனேன். சார், இப்படி என்ன மாட்டி விட்டீங்களே சார், எவ்வளோ உங்களுக்கு தெரியாது, என்னோட அட்ரினல் எவ்வளோ பம்பாக இருக்கும்னு உங்களுக்கு தெரிஞ்சிருக்காது அப்படின்னு. அதெல்லாம் இல்லை, யூ ஹேவ் டு ஸ்டார்ட் லேர்னிங் லைக் திஸ். நெக்ஸ்ட் டே மார்னிங் எனக்கு ஃபோன் பண்ணார், கம் இமீடியட்லி மை ஹவுஸ். போனேன், யூ பிகம் மை எனிமி. என்ன சார் என்ன சார் எனிமின்னு சொல்றீங்க? இல்லை, இப்போ ஜஸ்ட் நோ தே கால் மீ அப்படி சார், இனிமேல் நீங்க வராதுங்க, உங்க அசிஸ்டன்ட் அனுப்புங்க இனிமேல் அப்படின்னாங்க. அப்பதான் ஒரு வார்த்தை சொன்னார், I can never forget. On 2 occasions, son, he'll used to call me son. You'll never feel defeated. One, when your son defeats you, you'll never feel defeated. Your son does better than you, you'll never feel. Second, he said, when your student defeats you, you'll never feel. And the feeling I had when he came back from this thing, SCIATICA as a big time neurosurgeon when he came, I was so happy. I introduced him to Kaveri. Actually, he's still working in Kaveri also. And so such an eminent neurosurgeon. He's going to talk to, we have a lot of topics today. Low back pain, sciatica. நான் என்னெல்லாமோ I wanted, எனக்கு என்னெல்லாம் நியூரலஜி தெரியாதோ அதெல்லாம் வந்து I told him. He said, okay, facial pain, tics, palsies, and all other head injury, spine injury, all that. We are covering a huge lot in the next 2 hours. So be patient. After each speaker, your doubts, please ask them. Our 10-15 minutes we'll have session for question answer. You clear all your doubts before you leave. ஓகே. ஸோ இப்போ நாங்கள் வந்து நாவலாக இப்போ வந்து இந்த பழைய காலத்து மாதிரி இன்ட்ரடியூஸ் பண்ணுறதுலாம் விட்டோம். நாங்கள் இப்போ எல்லாம் வீடியோ, எங்களுக்கு ஒரு ராகுல்னு ஒருத்தர் இருக்கான், அவன் தான் எங்களோட வீடியோகிராஃபர் மாதிரி. ஹி டஸ் இது கொடுத்துட்டா ஓவரலாக கொடுத்துட்டு எல்லாமே வீடியோ போட்டு கொடுத்துருவாங்க எங்களுக்கு. ஸோ உங்களுக்கு எல்லாருக்கும் சிவி வந்து வீடியோவில் வேணா கிவ் இட் மீ, ஐ வில் கெட் இட் ஆர்கனைஸ். ஒரு 100 rupees சார்ஜ் பண்ணவா? ஓகே. ஸோ we'll start off with presenting our Dr. Shyam, neurosurgeon. He's going to talk to us on low backache and sciatica, which is very common. In fact, நமக்கே நிறைய பேருக்கு லோ பேக், 70 வயசு ஆனா பயங்கர லோ பேக் பெயின் இருக்கு. ஷியாட்டிக்காவும் கொஞ்சம் வந்துடுது இப்போ. ஸோ அதனால I thought that will be an ideal topic. So we'll start off with you. Can I have the scene? Rahul, come. He is from Melbourne University.
Dr. Shyam Krishnan is a highly qualified and experienced brain and spine surgeon with a special interest in skull-based surgery, neurovascular surgery, and spinal minimally invasive surgery. He holds an MBBS, MS in general surgery, and an MCH in neurosurgery. He has also completed fellowships in neurosurgery from the Royal Melbourne Hospital in Australia and in pediatric neurosurgery and epilepsy surgery from the Krishna Institute of Medical Sciences in Hyderabad, India. Dr. Krishnan has held various positions as a senior consultant neurosurgeon in reputable hospitals, including Kaveri Hospital, Chennai Meenakshi Hospital, Isabel Hospital, New Hope Hospital, and Fortis Malar Hospital. He has been actively involved in research and has published over 30 articles in national and international journals. He has also presented numerous research works in various conferences. Dr. Krishnan is a member of professional associations such as the Tamil Nadu and Pondicherry Association of Neurosurgeons and the Neurological Society of India. Dr. Shyam Sundar Krishnan is a highly qualified and experienced brain and spine.
Okay. You start off the presentation. Over to you, Shyam. He'll be there to stop and stop with all this.
Thank you.
On.
I'd like to thank Dr. Kailash to have given me the opportunity to speak with all of you and also to hold the stage to talk on a topic which is very common across the space. Sir has been a teacher for me because during my MBBS, after I entered clinical fields, I started sitting with him in the evenings. Pathology ஸ்டார்டிங் பீரியட்ல அதெல்லாம் படிக்கிறது பதிலாக கிளினிக்கில் உட்காந்து நல்லா இருந்தது. கேஸ் பார்க்கலாம், சார் அமுச்சு விடுவாரு ரூம்லாம் பேஷண்ட்லாம் பார்க்கறதுக்கு இல்லைங்களா. ஸோ அதெல்லாம் பார்க்கலாம். ஒன் சார் வெண்ட் அவுட் ஆஃப் ஸ்டேஷன் அண்ட் ஒன் பேஷண்ட் டைட், சம் ஓல்ட் பர்சன் எக்ஸ்பயர்ட் அண்ட் தே கால் மீ டு பல்ஸ் எல்லாம் பார்க்க சொல்லுவோம். ஒன்று ஃபோன் கிடையாது, இப்போ மொபைல் ஃபோன் கிடையாது. ஸோ கீழே ஓடி வந்து இங்கேருந்து லேண்ட்லைனுக்கு சார் ஃபோன் அடிச்சு நான் கேட்டு எப்படி டிக்ளேர் பண்ணணும் எல்லாம் பண்ணி. ஸோ it was a very nice time with sir that time. It was way back in 97, sir. So thanks, sir, for the opportunity. So the topic today is on neurological issues. We took some common issues which sir highlighted, and so I thought we'll make it simple as much as possible. So I work as a team. Myself, Dr. Kesavan, Dr. Vaibhav, we form a team and we work together in all cases. So we made it a point that we remain a team for 2-3 reasons. Is one, if I miss something, he catches it, and we are very open to ideas. Especially Vaibhav is very young, so even his questions, and we have a house surgeon with us also who also asks a lot of questions. So his questions are very important because they think out of the box, and that has helped me transition a lot of issues. So, and also we give a personalized care as a team. We're there all the time, 24/7. If I go on leave, he doesn't take leave. He goes on leave. Somebody or the other is there, and the team is well introduced. So we operate together. Even if it's a small subdural, we sit together. So that's our principle. So that is Dr. Vaibhav, the youngest in the team, and probably more grey matter than all of us. So he's completed 1 year back. Resolute fellow. He's from Nagpur, Maharashtrian, and then there is. He's also now an assistant professor in Rayapeta. So in the afternoon after 2, he joins me. And Dr. Kesavan is an assistant professor in MMC. And after 2 again, he joins me after his work is done. And that's how we work together. All surgeries happen in the afternoons. Our area of expertise has been quite wide. We do minimally invasive spine. Today being mainly spine issues and other issues. Neuro-oncology and cerebrovascular are close to my heart. I do a lot of endoscopic work. I like endoscopic work. And bottom line, with as any profession in medicine, clinical diagnosis, identifying the right problem, treating the problem correctly and sufficiently is more important. And where you don't sure whether you can give good outcome, let's not do anything harm and move away, don't do anything. We don't have to participate in their suffering or contribute to their suffering. Skull-based endoscopy and transventricular endoscopy. Sir. Skull-based is what transnasal endoscopy, pituitaries, craniopharyngiomas, certain clival lesions, chordomas. we can attend through the nose itself. And for the ventricular system tumors, we put an endoscope in and through the skull. Very large tumors we won't take out through an endoscope because it will take a long time and we can't keep doing anesthesia. But a small size tumor we can take out through the ventricle through an endoscope. So my topic today is low backache. Low backache is important because it's a most common problem which, as Sir said, not only patients but even all of us get. I think every 6 months we have some kind of a back pain nowadays. Now today, younger generation more common because they sit a lot. It's going to be more prevalent. So we need to know our back pains, which is important, which is not important. So I'll try to keep it as simple and also as less complicated as possible. I've done it entirely as a video so that we go down the process. So this is the spine. As you all see, the nerve root exiting from the spine, the disc, the vertebral body, all that is quite clear there. There are a lot of things which many of us you'll know, and some things I may repeat and some things will be novel. So the common problems in the disc, the facet joint, there are two joints here, disc and facet, these are two joints. So whenever we bend or we sit up, there is a lot of pressure in the spine. Bending is the worst. Sitting is also a lot of pressure. Standing is the best for the spine. So the moment you sit, the pressure is almost about 70% more than maybe idu total nallodu. So that is the thing. And this area, this is annulus which is there, and this is the nucleus pulposus, the center portion which is very soft. The annulus is good and strong through our age, but as we age, it starts fraying out. When we bend, there is a natural bulge that happens because this nucleus, which is basically pushed on the anterior aspect of the spine, the disc will naturally go back. So when you bend, there is a lot of stress on the disc. So that is quite common. So you see that pressure happens right there. And if there is a tear, the nucleus pulposus will come out through that because that is a maximum stress zone. So bending forward is one area. The other fact of the issue is the presence of back pain is also increased by you sitting for a long time and also awkward position. Now this is a contained nucleus, faucet, contained nucleus. Here it is bulging, but the annulus is still intact, though the nucleus pulposus is not coming out. The previous video you saw it coming out. So there are two components to the disc, the annulus itself bulging or the material within, that is the nucleus pulposus, soft jelly-like material, that coming out. That's the worst, boss. That's the worst because it produces a lot of chemical reaction. And the worst thing is that is something which has never been exposed to much of blood supply and it's been there since our birth. It's a notochord derivative. So the moment it comes out, it unleashes a severe reaction because it's a foreign body as far as the body is concerned, and the inflammatory play out is quite severe. Next.
But sitting, you will not get it out
by sitting?
Bending, you will get it out.
Sitting also the pressure increases to almost 40% more. Bending will go up to 170%. Sitting awkwardly and bending worsens it even further. The way we sit, it's bad. The photo is not seen. The disc, when it comes out, it frays out all these areas of the ligamentum flavum that get thinned out. And as time goes by, that frays out and the disc starts protruding because this annulus fiber starts giving away, starts thinning out gradually over a period of time as we age, or severe wear and tear also, unhealthy wear and tear. And once that happens, the disc starts bulging. This is known as a classical disc bulge. The disc is only bulging, which will be seen among a lot of patients. So now you also see that there is a bunch of nerve roots here, and at each level the nerve root comes out. At each level the nerve root comes out. And here, as you see, it bulges out and it's just about touching the exiting nerve root. The nucleus pulposus is still intact. It is just a bulge. Now it tears and the nucleus pulposus comes out. This produces a severe reaction which we always face with these patients. This results in the nerve root irritation, and according to the level we start getting the radiation of pain. Yes, the same theory applies across the length of the. So that is, see, there are two aspects to it. One, the muscle strengthening, the strength of the muscles above and behind, which the strength of the muscle above and behind the disc, that is a posterior sign cantilever mechanism, which you have these longus colli muscles in the back of the, on either side of the spinous process. These hold the muscles and the disc in place. So when I bend forward, the amount of stress that falls on the disc is reduced by this cantilever mechanism of the strengthening of the back muscles. No, if you kept it strong, then it should be good. Core exercises, good core exercises. That is the best way forward. As we age, once the disc starts losing the nucleus pulposus dries out, the risk of extrusion, this kind of an extrusion won't happen. You end up with more of canal stenosis, foraminal stenosis, arthritis of these small joints which I showed before. I'll again come to that. So those become the issue. So in the earlier age only you get these big pop-outs. Next slide. So this is a typical person coming with an antalgic gait. This is how he walks into your office. If in your clinic, he'll walk with that gait typically tilted towards the side of the problem so that he can accommodate the nerve better. Previous video loaded. So this is a correct scoliosis of this patient. I can see the complete angulation of the spine here for her. And you can also palpate the spine of a patient. When you do palpate, Sir will demonstrate. You palpate along the center of the spine. Yeah. Center of the spine, feel the center of the spine, feel it. And then you touch it down the line. This is for any patient on your clinical bed, you can do this. Check for any pain. From our point of view, any pain in the spinous process would mean either a local strain of the ligaments, or it could mean that the patient has got, now can be TB also, you should remember, any gibbous you can feel. Next is, you feel the paraspinal aspects. The paraspinal aspects are two things. One, now he will just feel, you look for, if he moves the muscle there, that is muscular pain. You just hold the muscle on the side and you move it. If it pains, then it's probably muscular pain. So how do you differentiate muscular pain from, is to feel point tenderness. You will go around with this, keep pressing with the thumb along the sides of the spine. So you keep pressing, you will feel the facet joint on the sides, and those tenderness are different from a muscle pain. In the beginning I had shown you in the scan. So these are a couple of tests we need to do. One is a straight leg raising test. This is for classical sciatica. Lift the leg up, and there's a cross straight leg raising where you raise the leg and the opposite side starts paining. Then the femoral stretch test where you ask the patient you lift the knee joint up with the patient prone. And then last is the Faber test. Next slide. These are a couple of clinical tests you can easily do. Classical leg raise at about 40 to 45 degrees. If he starts having pain, that's a classical sciatica. And that's because the nerve is getting stretched. Now what you can do is you can lax the leg a bit, reduce the leg a bit, maybe to about 30 degrees or 35 degrees, the pain will disappear. At this point, you can simply extend the ankle, the pain will again come back. That's again demonstrating a sciatica. The other simple test which you can do is sitting on a chair. You can ask your patient to simply lift his leg. If he's having pain, that is it's the first sign that there's probably a sciatica. Now, yes, you can confirm if you have a couch by making them lie down and do the same test on the side where the leg was paining. So that will first localize the side for you. And that's the thing. Lax it down a bit and then stretch, dorsiflex the ankle a bit. The pain will aggravate. The contralateral pain is when you lift the leg, this side the leg starts paining. That's not a good sign because that means the disc is affecting both sides. Or you're probably having a disc on the opposite side also. Next slide. So these are very basic tests. Of course, when you're doing these things, you should also look for knee tenderness. And the patient may be having arthritis also. So you should be careful when you do it. So better to ask the patient themselves to lift their leg rather than you trying to do it, because the pain, if there is some arthritis or something, senior citizens especially will be helping in pain and it will mask the other pain. So you'll miss classical disc training. And also hold the knee when you're doing it, especially for senior citizens, hold the knee so that you gradually extend the knee and then lift it up. Or bend the leg at the knee joint and gradually lift the knee and then go up further. So you had a Faber test now. Go back. Go back. Okay, enough. Yeah, play. Next, move forward. So this once a person has got a leg raising test, that's possible. Possibly he's got a disc in this form, which is what you should anticipate in the MRI, and that is the first thing to look for. Next, that's a classical disc. This is a nice nucleus pulposus. This black thing is the annulus. So nicely hydrated nucleus pulposus, and here it has come out and is dehydrated fully. Next slide.
You do MRI to any elderly person, they always give neural canals,
Yes. Symptomatic only I'm talking about. Symptomatic in terms of clinical findings. Not all patients with back pain or significant canal stenosis are where the picture requires us to get interfering in. Otherwise, we don't have to interfere. Most of the time, it is simple vitamin D3 deficiency, or very often it is pure osteoporosis. These are the usual causes. He might have had the same scan with that much amount of stenosis even prior. Only we might have that particular event of muscle strain or a simple facetal arthritis. These kind of things might be the reason why he is coming with pain. A simple nerve root block or a facetal block would solve the problem if it is that the case. But first we rule out other things like vitamin D3 deficiency or something like that and take it forward. I will also come to some red flags where you say, no, you need to evaluate it further. Next slide, please. So most of the disc herniations happen at L5S1. That's the most common because that's very close to us. L5S1 is a sacral junction. That is one thing moves to the other. The lumbar region moves to the sacral region. So it's a junctional vertebra. And also it is a direct transmission of entire body weight from a particular kind of a column to another column. So the dynamics of the L5S1 is very high. And so the chance of discs are higher there. So the next is the sacroiliac joint. Go back on the sacroiliac joint. And in the sacroiliac joint, we look for what is known as a Faber's test. This is a sacroiliac joint. So we need to rule out that maybe the pain is arising from the sacroiliac joint rather than from the disc. Next. Now for this, what we do what is known as a Faber's test. Faber's test is the set you just lift your leg up and keep it on top of the knee on the opposite side and give a gentle press this way. And if that hurts here, then it's probably the sacroiliac joint which is the cause for the pain. You support this side and press the knee down. Senior citizens always be very soft. They may have hip issues. Please confirm whether they got on the processes inside before we do all that. Because I have done this press and I have found somebody having a knee arthritis and they just yelp in pain. So the purpose is to disconnect that pain from this pain. If you mix both, then you'll never get the answer from the patient after that. Next. So that demonstrates it nicely. The not moving. Now the flexion. Also another test you can simply do when you ask a patient coming with back pain, ask him if he can bend. If he is not able to bend or the pain is aggravating with bending, then probably it's a disc problem, because that is the most common problem which we all face. Discogenic pain, best way to identify is a flexioning movement. So the moment you flex, the disc bulges backwards, so it is causing the pain. So that is a simple thing which can probably tell you that the patient is having a disc. All these are all arbitrary. These are not.
Every time you bend forward, this will go back.
This will go backwards, so it will compress the nerve. So you'll get that radiating pain. So that is a very classical finding you can look for. We are not looking at tests as individual. We are just combining multiple tests and then drawing some conclusions. So you can tell me, suppose somebody has got a muscle strain in the back. You ask him to bend, obviously it will pain. He's got facial arthropathy, yes, it will pain. But what I'm trying to say is you mix and match all these tests and you get some derivative logic out of it. When you bend backwards, the stress falls completely on the facet joints. Now these facet joints are right here, the back of the spine, where this is the joint, so it is attached there. And these joints is where the pain starts happening. Play. So that is where the movement is happening. The movement is not only happening in the disc, it's also happening here in that joint. And that can break at some. There's actually a fracture here. The joining of the two joints can also break. Now you can see this, the nerves, how they come out. And if the so you see here, this is a nerve coming out of the spine. If there is a disc, it will compress this nerve. And this is a foramina through which it comes, a very narrow space. Now because of arthritis, if the facet joints becomes inflamed, the nerve also has a supply to that. So when this inflamed joint starts playing up, you start having the same referred pain as the disc. That is, if the disc comes out and it compresses this nerve, what pain you will get, the same kind of pain can come as a referred pain by arthritis in the back. So when you ask the patient to bend backwards, that inflamed joint is going to play up. It's going to pain like hell. And also when you do this extension, this foramina becomes narrow. So you know that the patient is doing this and he gets pain, it's probably the facet joint which is probably involved, is what you should think about. So spinal stenosis, when he bends back, he's going to have pain. So because the entire canal becomes narrow, the foramina becomes narrow. But when it comes to continue. Yeah. So extension is where the canal becomes narrow, 20% decrease in canal stenosis. So already if the canal is tight, with this movement it will become even further narrow. And if he has got a facetal arthropathy here, he's got a disc here, that foramina is going to get even further narrow. And if it does, then the patient will have a severe pain in the back and radiating downwards. So this is one thing. Here you can have a combo of both the disc and but flexion, if it's a pure disc, flexion will cause the pain. The disc alone will be the cause. Next slide. So very often you'll ask them climb. If you're climbing staircase, your pain will be less. Why? Because he'll be flexing forward. But when he's climbing down the staircase, he'll have less pain. That's because of the external flexion concept. This is a classical spinal canal stenosis or foraminal stenosis, plus or minus facetal arthropathy. So we just go through quickly all these nerves. I've kept it as a wide video just for evaluation. L1 is sensory in the beginning area. You will have sensory discomfort right under the underwear, beginning underwear cut here. And then you have the, don't disturb it. When the patient reflexes you look for, and you also look for motor components. So if the D12L1 is disc there, which is very rare, you may end up, the most common thing there is usually a tumor rather than a disc at L1, L2, very rarely. We did operate on an L2, L3 disc day before yesterday, but which are classical symptoms as we are presenting today. And but these are rare dislocation. Usual common is L4, L5, L5, S1, and very rarely L3, L4. Continue to play. Don't stop, play. Yeah. So when you have an L1, L2, L3, it's usually the pelvic flexion areas. L1 takes care of flexion and it also takes care of adduction. No reflexes are involved with this particular nerve root. L2 is also almost the same thing because L2 usually takes care of flexion, iliopsoas is the main supply to the L2. And also it takes care of sensory in that area. Best way to look at the sensory is the cremasteric reflex. If it's a man, you scrape around the medial aspect, the cremaster will contract, the scrotum will shrink. It also produces adduction besides flexion of the hip. I'll quickly run through this for completion's sake. Very rarely extension. If you want to really look for the reflex, that's no deep tendon reflexes are attributed to it. L2, L3 disc is an interesting disc because it compresses the L3 nerve root. Now, L3 nerve root is a very important nerve root because you can easily localize it on the knee joint. The knee joint area is L3. The reflex it attributes also is the knee jerk, both L4 and L3. L3 and L4 can overlap. And it mainly also contributes towards the hip flexion. It also helps in hip adduction. And a good component of it supplies the knee extension. So it's a very strong nerve which contributes to two major muscles. When the L3, L4 disc is hit, it affects the L4 nerve root. And that supplies the medial aspect of the leg. So this is how it goes, L2, L3, L4, L5, S1. So you think about it as if you're putting your hand in your pocket, So you go L1, L2, L3, L4. The the greater toe is L4, remaining toes are L5, the little toe is S1. And your sole of your foot is predominantly S1. So that's easy way to remember sensations. This is a very classical test. It's known as femoral stretch test. But by this time, we would have already localized L4 because the knee jerk would be absent. This test will give severe pain in the front of the leg for the patient. L5 is a very important nerve root, very common disc at this level, especially among younger patients. And as I told you, all the toes except the little and the great, anything below the knee on the center aspect of your leg. And the big toe extension, that contribution comes heavily from L5. So I will consolidate all these tests to little tests in the end so that on a day-to-day practice it will be easier to know where the problem is. This is a very important test for gluteal muscle because if you ask a patient to stand on one leg, he will not be able to. He will give up on that side where the pain is, where the nerve root is taking care. That is a gluteus medius. So and because he can't stabilize his hip, he will tend to not be able to bear weight on the other leg. And the classical SLR positivity happens with L5. But please note here, even an L5 S1 disc or a L4 L5 disc, or an S1 level disc can also compress the L5 nerve root, because the nerve is much more larger, the space is also large, the disc will accommodate and become bigger also quite well. Again, S1 is involved, you know for sure that the patient's having paresthesia in the sole predominantly, and also he will have sciatica, and another very important thing which patient has is plantar flexion is lost. Aversion of food. This is a very subtle sign to look for. This we already did. So I would quickly demonstrate. So when you ask a patient to do a heel walking, the classical way you ask a person to do a heel walking is to walk on his heel. This, if they are not able to do, if the person has got a L4 or an L5 nerve root involvement, he won't be able to do this. His leg will keep falling down. And if he has got an S1 nerve root issue, you ask him to walk on his toes. He won't be able to do this. One side will give up and he will not be able. So ask him to do a heel walking and a toe walking. Very simple test to do in the ward. So this is plantar flexion of S1. Okay. Dorsiflexion of the ankle is L4. L5 is the toe. So dorsiflexion of the foot is L5, L4. Toe is L5. Down is S1. So all these three tests you can easily do it on the bedside of the patient. The heel walking and toe walking. When the patient comes inside, you can see if he's got an antalgic gait. Feel his spine, you'll know the tenderness, you'll know whether extension is causing pain, flexion is causing pain. I think these 5 tests itself gives you a more or less clear parameter as to what you're looking at. And because these are the most common levels for a disc to come. Next slide. Sensation is very simple, as I already explained this to you. Proceed. Reflexes we already seen. Spondylolisthesis. Now, the other issue is, we talked about stenosis, the canal stenosis, how to identify. The other very important thing is, when there is canal stenosis, all the nerves are compressed. The entire cauda equina nerves, that's the nerves that are coming down, will be compressed. So it's a large central disc. Patient is going to have neurogenic claudication. கொஞ்சம் தூரம் நடக்க முடியுது சார், கொஞ்சம் தூரம் நடந்தா கால் மதமதப்புன்னு ஆயிடுறது, கால் ஒரு மாதிரி குடைய ஆரம்பிக்கிறது, முடிய மாட்டேங்கிறது சார். நெக்ஸ்ட் வந்து சார் நடக்க முடியல, கொஞ்ச நாளா தூங்கவும் முடிய மாட்டேங்குது, நைட்ல கால் வலிச்சுட்டே இருக்கு, கொஞ்ச தூரம் நடந்தானா கால் வலிக்குது, கொஞ்ச நேரம் உட்காண்டா சரியா இருக்கு, கொஞ்சம் குடிஞ்சா பரவாயில்ல வலி குறையாது. This is classical features of canal stenosis. So canal stenosis like this clearly means there's probably no disc. This is a spondylitic spine. The disc is dried out. Because the disc has dried out, the vertebral bodies have collapsed on each other. And once they are collapsed on each other, the foramina is narrowed. And there may be osteophytes, no disc. Disc means the soft disc is replaced by bone. And that is all kept the space tight. There is no chemical issue here. It's pure mechanical stenosis. Now, if this progresses, what happens is that these one bone may slip on the other. This sometimes happens either because of a disc or this connection in the back of the spine is becoming weak. This is another problem where a stenosis can happen. One because of spondylitic changes, the other one is because of spondylolisthesis. Here what happens is the same thing. One bone has slipped on the other and tightened the canal. Continue. So only these are the two positive issues that you need to look at when you look at claudication. When you see claudication, my MRI is going to be expectantly showing me a listhesis or a spondylitic spine with canal stenosis secondary to osteophytes and all those. When you say canal stenosis, it's purely vascular compromise for the nerve. Red flags. Bilateral foot drop. If you see a person coming with a bilateral foot drop or a unilateral foot drop itself is good enough for immediate surgical reference. Of course, you need to rule out whether it's neurogenic or diabetic. That is definitely a given, but it is a red flag. So whatever be your clinical acumen, please get an MRI. We may be having an overlap of both diabetes and something funny going on. And bilateral is immediate. You need to move the patient quickly for any treatment. Bilateral foot weakness. You ask them to go on their toes. They are not able to do bilaterally. There's something wrong. But on the heel, please immediately get an MRI. Don't wait. These are red flags. You may be 100% MRI may be normal, but it's a red flag. Do not ignore it. Next. See. Bilateral buttock pain coming bilaterally, not unilaterally. Usually they'll say buttock pain even for L5, but if it's bilateral, be concerned. Maybe you're looking at a cauda equina. Any bowel bladder problem when you're treating a patient conservatively, it's a red flag. He says that he's having some urinary issue. Please get an MRI immediately. Probably needs urgent surgery. You need to decompress. Point I'll again repeat, if you have an acute disc, especially L5, S1, patient may naturally have some urge incontinence, especially senior citizens. They may end up with all these things. It may be nothing to worry about, and an MRI may not show much of an issue. But do not neglect it because these are red flags for a cauda equina syndrome. It may not come in full cluster, it may come in pieces. Severe groin pain. These are some. When I worked in Melbourne, the thing is that the system of getting a patient into the treatment office of a neurologist or a neurosurgeon is so difficult that a lot of these discs in the earlier stage are missed there, and the patient unfortunately ends up very bad and come. I think you had some experiences. So the treatment modalities is so drawn long that patients actually come in very. So in Melbourne, I used to see a lot of these patients presenting with severe groin pain and coming, going to the urology office, ruling off testicular issues, and then finding a disc. So groin pain also you can keep it as a red flag. So weakness, bladder and bilateral pain, bilateral weakness, any weakness, bladder issues or bilateral pain, please consider it as a red flag. Next slide. And very important is, I always feel the pulse of all my patients in their legs, especially if they are smokers, because the last thing you want to miss is a vascular claudication. The last thing you want, you can miss a disc, you can retrieve it, but for dorsalis pedis, posterior tibial, please palpate for all leg pains as a rule. So the initial steps I would like to, what happened? Something happened. So this is the, I'm not using the pointer because it seems to be changing the slide or something, hence I'm using the finger. So this is a nerve root which comes out, and these are the supply for this facet joint which comes from the nerve root itself. So as you see, if you put a block here, you can catch the nerve as it is coming from here, and we can give a steroid mixed with some xylocaine and bupivacaine, and we can cut the inflammation to this joint, and by doing that, that referred pain you can cut off. So it will give relief to the patient. I'll come to that. So we can do that. And also there's a counterintuitive point which runs in everybody's thinking, is that the inflammation also reduces because it's like the Sudaks phenomenon, the neurogenic component aggravates the process. The inflammation comes down in these facet joints. The other thing which you can do when you're giving a block is you can silence this nerve also with a selective nerve root block, where you take the needle and you go in, put a dye, check that you're on the nerve, and then you inject the combination of bupivacaine, a steroid and a xylocaine and calm that nerve down. This is especially useful for a stenotic patient presenting with a one. Second thing, it also helps you localize the problem. You hit that nerve correctly, patient is awake, you give the block, patient feels relief, you know for sure that that is the cause of pain. And if you feel the whole pain is facetal, even if it doesn't work, it's okay, but you're not done much, right? So your pain is relieved, patient is comfortable. Even if it works for 6 months, you can put anti-inflammatories, ask him to do proper exercises and come out. Even if it's 4 weeks, great. There is enough time for him to not suffer and also recover from the so this is a definite method. Another thing which you can do is you can even give suppose the pain is not localizing to both. You can also give a discogram. Sometimes a tear in the disc can also precipitate pain which is discogenic in origin, where you can't localize the pain at all. So that kind of pain, if you give a discogram, and that will tell us in that stress that the pain is aggravating with. So next slide. இது மிஸ் பண்ணாட்டு பிளாக் போட்டதுலாம் இல்லையா? Why? You can pause it and play it elsewhere. So that will be very nice to show. Okay, it's not playing, huh? Okay, so I wanted to show you some nerve root blocks, but that's okay because that's fine. It's not playing for some reason. So now I thought I'll talk to you about some. Before I finish this, start this. There are some very interesting things. Why I talked about nerve root block. Now, if you have a person with a disc, not this kind of a disc, I'm talking about small disc sitting in the foramina. Patient is neurologically okay, and say he's got a sugar of 450, his BP is 170, 80. For next 5 days, you keep him on pain and multiple painkillers. You give a block. At least you can tide over that period before you even plan for any surgical intervention or natural healing also. So nerve root block sometimes may help. Now, if it is too tight a disc, the injectable dye and the medicine may not even go through because of the tightness of the space. In that case, you can at least try. So it can also be used as a bridging, diagnostic, as well as beneficial for the patient giving these blocks. Next slide. And it's just a needle, it's LP needle which mark பண்ணிட்டு கொடுக்கறதுதான் பெரிய ஒன்று கிடையாது. And sometimes we have had some diagnostic confusions whether when it looks like facetal pain, nerve root pain, the scans are not interpretable. We have gone ahead and given it, and we have had some fantastic results also. So this is a microscope which we use for a microdiscectomy, and this is a Carl Zeiss microscope. These are some instruments which we use. I just quickly show some videos on surgery. We select the level of surgery with a marker pen, just a 2 centimeter incision that is less than a phalanx of your finger. The more bigger the patient, the more easier for us to do it because we have space to go in, and at the depth it's much easier. It's counterintuitive, but that's how it works. And it's very much a boon for a thin patient. Even this much I can use a 2 centimeter incision and do a microdiscectomy even without a special instruments. These kind of special instruments. But for an obese patient, you need to make bigger incisions to reach at that depth. So for them, and most of our patients today, we use these kind of retractor systems. It's just to give you the novelty of how minimally invasive thing works. So these are multiple dilators that have been used which are going through the muscle. We are not stripping the muscle off or cutting the muscle at all. This is exactly 2 centimeters, this diameter of this hole. We can choose a size up to 24, we can use 2.4 centimeters. And once we localize the level, we know where we are. And then we can start operating through that narrow space. That thing holds in place. So now we are just drilling off that's how we see inside through that. That is a lamina. And that's a drill. That's probably a 4 millimeter drill tip. We can correct the bone out. That's bone wax to prevent the muscle blood coming from the bone. Mind you, this all within a 2 centimeter diameter. Taking out the ligamentum flavum. And that's a nerve root, which you can see. And as we lift the nerve root, the disc is so tight under pressure, it will just pop out. That grey thing is the disc which is coming out. This is the disc, and that's a nerve root. The nerve root is moving aside, the disc is coming out. You can see how much of pressure it has been under. The disc is not something which you're taking out from inside, it's already out. And people ask what will happen without the disc. Nothing will happen, it's already started a process. As we age, the disc will dry out, the annulus will already given out, slowly ossification will start and everything will settle off. So nothing is going to happen. You don't have to replace this particular disc. And that's it. That's the size of the disc. The size of the incision is only, as I told you, just 2 centimeters. The nerve root is free. Some fragments are there, we search around. Nothing is there, it's clean. And that's it, just 2 centimeters. And on a younger patient, on a thinner, less obese patient, it doesn't make a difference. But the impact which we see in much heavier patients is that it's amazing, because otherwise we used to make big incisions before. That's it, the incision size. That's all. And this is another case where we are, this is where I told you that the bone slips one over the other. That's kind of surgery where we take out the disc, and here we need to fuse it because the bone has slipped out. And again, through the same opening, we put the cage and dilate, put percutaneous screws inside, fix it. This is one bone slipping over the other. Severe stenosis, because the moment you take out this stenosis, you drill it out, the bone is going to be, already it's moving. It will even destabilize even further. So we stabilize it. This is how we mark the level. We check the sides, the boundaries, where to go in. We put the dilators as I had already shown before. Same dilatation system. Same using microscope. Same processes. So the question is, when do you put screws and when do you not put screws? We have actually, on a larger scale, we have stopped putting screws for very senior citizens. Above 70, we don't, 65, 70, we don't put screws at all. We try to do minimally invasive, just fenestrations. Sometimes if we can't put a MIS system because we can't get an angle, we do open. We avoid screws as much as possible because the osteoporosis of the bone, how much ever you replace, it may be selective osteoporosis. It could be one vertebral body which may be osteoporotic. The other levels may not be osteoporotic. Any complications and long time of the surgery, all these things we avoid generally putting screws. And not only that, if they come back and get admitted due to some kind of a sepsis or down the line deteriorating patients, you would have put a screw 3 years back, and then what happens is that he's on a bed for a long time, bed sores come and the screws start getting exposed and all. So I tend to avoid as much as possible in a serious citizen putting instrumentation. And we tend to put predominantly in younger groups of patients where the load of work is going to be moved. They're going to be sitting long. They're going to be doing all these things. It's better. And very often than that, I feel that most of these senior citizens, the bones don't move, though they may have listhesis. They don't move because already osteophytes have formed. The disc space is already fused naturally. It's just that the bone has grown so much that it is creating a stenosis. So just release the bone through small openings, clear the nerve wherever the level is problem is, and leave it alone. We don't have to get back sagittal balance, coronal balance and all that stuff. As long as he's pain-free after surgery, that is good enough. So this is again through the MIS. So here we are stabilizing in a young person because of the movement. And we know that by decompressing his spine, he may become worse. So hence, we have put these videos of taking out the disc. This is a more challenging work than a simple discectomy. But again, everything is through that 2 centimeter gap alone. In forward. 2 centimeters. That's all. It's exactly 1 phalanx. That's all it is. We have an option to go up to almost 3 centimeters. That is the dilators. We can choose larger dilators depending on the situation. And there are systems which just a tube goes in and it opens inside. So though we may have a smaller entry, we can open it up inside also. But again, just because we are having this, we don't do it all the time. There may be situations where the particular port may not sit properly. And if it doesn't sit properly, we may destabilize the spine, as well do it open. So when we take a consent, we take a consent saying that we will do it predominantly closed, but sometimes we may open it up also. Or we tell them this is not a good candidate for. Sir. Yeah, there has always been a overlap between orthopedic and neurosurgery for a long time. The instrumentation trend, I think they started off much earlier than us. We remained in the non-instrumented field for a very long time. So that changed probably in the late 90s, where we also started going into. But most of the development in orthopedic, in spine, in terms of instrumentation, happened with one Dr. Ramani from Bombay, who was a neurosurgeon, and he introduced stainless steel screws in India, stainless steel cages in India. So in Bombay and North, it was predominantly neurosurgeons who dominated the instrumentation field. In South, it was more the orthopedicians who took. So that now it's more or less balanced across this country, with each one having their. But we still get to get called for maybe CV junctions or complex spines. Most of the scoliosis, they seem to be doing more. Yeah. So if you have a CV junction, that is craniovertebral junction issues, they usually end up calling us because anything going down that area and it touches the medulla or it touches then it becomes a problem. So those are the issues. So this is a patient in the post-op period. She's quite comfortable. And those are the sizes of incisions which we had to make.
How many ports?
Depends on the number of screws we put, sir. So it's 4 screws, 4 holes. And if it's more than that, then more. Usually it is 4. Sometimes it goes to 3 on each side. 2 on each side or 3 on each side. Beyond that, the stabilization requirements are not that much, at least. Under general anesthesia. Also, it has endoscopic spine work also going on. Same thing. Now microdiscectomy, you saw the microscope, right? So same thing, microscope with microdiscectomy. Only thing, the ports are smaller. You're doing it through those tubular ports. So you can then choose between the microscope or a loop. But then if you have a loop, you need a light which is focused, not a spread out light. So then you can't see inside that. So microscope is easy because it automatically focuses the light deep inside. So it's the same microdiscectomy. Only thing, the incision has become even more smaller, and you precisely keep it where you want to keep it and do it. And there's no difference as far as I'm concerned whether you do it open or closed significantly. But then the recovery period is very quick. They're ambulant, the pain, surgical site pain, everything comes down significantly. Yeah, endoscopic spine is being done. I personally don't do endoscopic spine. I use predominantly microscopic. The advantages for me with the microscopic spine is that I can increase the distance where I want to operate, or if I have a change in plan, we can open quickly. So all those benefits are much higher with and also you need to be very selective when you use endoscope. You can't do that, you can only do this. Those restrictions are there till now. But I'm sure it will also evolve into its own space as time goes by.
There is a situation like multiple is like that how you are doing that.
Multiple discs at the same level, sir. Oh, this one has come, huh?
The nerve root block.
Okay. Can I just take a minute off? This is a classical nerve root block where we enter the foramina and we inject the dye. This is a Sadhana Omnipac dye now, which we put for CT, yeah? And then we see where we are and we give the block. This is a facial block. As I showed you those nerves which were supplying the joints. No? We select those nerves and give blocks there and also into the facet joint. Next. That's a facet joint, we are giving it directly inside. Synovial joints. But along with the nerve, you can give, same thing, go up a bit, you'll give it into the nerves which supply the joint itself. That reduces the pain nicely. Orthopedicians, anesthetists, yeah, as long as you know to do it, you can do it. Yeah.
Pain clinic they have.
Even pain management is a separate today thing is there. There's so many, it's a
6 months to 1 year, that's all really.
depends on the case, sir. It sometimes works and probably that inflammation is tided over and then they are comfortable. I'm talking to facet joints and all. I've had some patients who have done well with that and they have not come back.
So
They're
what
comfortable.
is
And even if you can give it again, there's nothing, it's not so, not very expensive also. You can choose to do it on the X-ray table itself. I'm a paranoid person. I keep my anesthetist standing anytime I do something. So, safety margins.
Well, there are some osteoarthritis with osteophytes.
Yes, sir.
Then you do
We may not be able to enter the joint then. So, we'll give the nerve root block and we'll come out. Nerve root block meaning the synovial joint supply பண்ற nerve block பண்ணிட்டு வந்துரும்.
But what happens to the osteophytes if there are any?
It will be there.
Then it will recur again.
It may recur again. Now, if you want something definitive for that, we'll have to take it out, open surgery, take it out, put screws, fix it off. But sometimes it doesn't really, see, it's a process of aging, right? These osteophytes, the aging of the joint, which proceeds with these kind of problems. So many of, as time goes by, this joint will fuse. And once it fuses, it is not a hypermobile joint like the knee joint or the shoulder joint or the elbow. These are not hypermobile joints. These are mobility joints only, minimal mobility. So patient usually the inflammatory phase crosses, then there is no necessity for it to be of any issue. Lot of people I've seen actually very young senior citizens having very nice nucleus pulposus, and there are senior citizens with completely spondylolytic spines, and incidentally nothing is there, and they don't have any symptoms for that, and they are fine. So it's only one or something is happening at that time which is causing them to come to you.
Why is it elderly people generally bend forward all the time? Bone forward and
I think it's more of a muscular issues, combination neurological issues. I think
not the spine.
it's not the spine alone. I think the posture of looking more, holding forward to go, moving forward rather than backwards. Probably the osteophytes have joined together in the back. They can't do a full extension, so they move forward. There's so many factors to it.
Specifically good for the pulpus or the disc. Foot.
I think proper exercises, be on time, do not sit in awkward postures. I think those are things that
No food is there.
not that I am aware of. Sir.
There are some drugs like not chimerol, some common drug for the cartilage. Is it good for that?
You can any cartilage anywhere works.
Chondrite.
Any cartilage is every cartilage anywhere in the body, so you can.
But is it really
It may be helpful. No, I have not personally thought about it.
not that helpful?
Yeah. But probably because the wear and tear in other joints are higher. Here the wear and tear is not that high in terms of the immediate dynamics after the problem starts.
Athletics get more of this problem than others.
Uh,
They're jumping all the time.
Possibly, but also another caveat to that is probably the muscle strengthening is much better. So the transmission of those issues to the disc and all those things are less.
So gym exercise will be good for these people.
Because they play functional games, probably those functional games support the overall muscle, tendon, ligament, cartilage, everything is preserved in an overall sense. Gym is probably not a functional exercise and it probably doesn't help. So a tennis player is probably more fit in all aspects than probably or gymnast may be much better than a weightlifter maybe. Yeah, just play. It's over.
This is the pressure.
Yeah, this is the pressure percentages which you had asked about roughly. So when you're lying down, you're on the best, and it goes down the. When you bend forward, when you sit and bend forward, you don't sit properly. It becomes worse and worse. Sitting is a worse. As a matter of fact, post-operatively, I ask my patients either lie down more or walk more rather than sit for at least 2 weeks. The traction on the on your forward center of gravity moving forward, all those things are a big factor. More inflammatory. So that's us, all the three. Thank you. Thank you.
That was wonderful, Shyam. I'm so happy to hear it from you.
Thanks, sir.
The video presentation was amazing.
Thank you.
In
Thank you,
fact,
sir.
after seeing this, I'm trying to do something for asthma as a video presentation.
It's a video presentation. Thanks,
So on
sir.
behalf of Independent Medical Practice, the President will hand over a small memento to you.
Thank you. Thank you so much, sir.
Let me take a photo.
Thank you. Thank you so much.
We have a next speaker.